next speaker needs no introduction. He's Dr. Jerrold Lerman, and he will speak to us on how to manage the particularly big child undergoing anesthesia. Dr. Lerman, please.
Thank you very much. I apologize for being late. We had a very enthusiastic workshop down the hall, and I left and they were still asking questions and discussing ventilation of neonates. So I appreciate the change of the order of the speakers, and we'll try and keep you on time. So we have a problem. We all have a problem. We know there's a problem. The weight of the average person, whether it's a young child or an adult, is increasing dramatically over the last 10 to 20 years. These are my two grandchildren. They're not what we would call obese, but they could, under the wrong conditions, become exposed to high caloric intake and low exercise, playing too many electronic devices, and find themselves on one of these curves which show the proportion of overweight people versus the number of years, where this is 2020 predicted, this is 1970. And you can see in virtually every country, the flattest perhaps is maybe Austria, where the proportion of the population becoming obese is increasing dramatically. That's the bad news, but there is a glimmer of good news in that the educational aspect and all of our parental advice seems to have begins to have gotten through to parents, because when one looked at the incidence of obesity in young children, the youngest age group has a reducing incidence or prevalence of obesity, a reducing prevalence. So there seems to be some improvement on the horizon, and hopefully that will be translated into later years, that the children will not turn into obese teenagers. Now, we're going to talk about a number of aspects of obesity, so you can actually understand that when we have to face a patient who is obese, we actually are dissecting their obesity into components. And let's begin with the classification aspect, because the classification of obesity in adults is pretty clear. If you're over 30 BMI, you're obese. And if you're 18 BMI, you're underweight and possibly anorexic. We don't have such simple BMI metrics in pediatrics, because you can see what happens to the BMI with age in this one set of graphs. It is not linear. So a child at age 2 with a BMI of let's say 21 is actually morbidly obese. But as they get older and they hit age 10, they need a BMI of 26, and that's obese. We're not even at 30. So the issue is, in pediatrics, what is obesity? And it is not just simply the BMI more than 30, because the BMI for the average child is a nonlinear curve. And basically, they have to be greater than the 95th percentile to be obese. They're overweight below the 95th percentile on that curve. But if they're at the 95th percentile, they're obese, and beyond the 99th percentile BMI for that age, and male or female, then they are morbidly obese. Now, we don't know these curves in our minds, and so it's very difficult for us to be able to categorize the children, but we can at least keep in our minds a very simple formula that allows us to estimate the ideal body weight for the child's age. And then we can get an appreciation. If the child is more than double their ideal body weight, the odds are they're in the obesity category or more. And the simple formula that you can use, and it is very trustworthy, that I've used for 25 years or more, is that for children under the age of 8, you simply multiply their age by 2 and add 9. That should be their weight in kilos. So a 5-year-old child should be 19 kilos or 20 kilos. If they're 45 kilos, you can bet before you see them, you know they're obese. Over the age of 8, it becomes a little more difficult because you hit adolescence, but generally their weight is 3 times their age. So a 12-year-old should be about 36 kilos. And that gives us an idea of what the ideal body weight is in a child, and we can then extrapolate what the obesity level would be for that age. Now, obesity affects a number of organs, and they're all shown here. We don't have time to really address all of them. The important aspect of this issue is that the airway has been a paramount concern in obese patients, beginning with adults and in children. Intravenous access and handling these children, because mentally they seem much older than they really are. They're often immature. And if you say, oh, I'll just put an IV in there, they'll break out in tears. So you have to be very compassionate with them, more so than normal, because you're underestimating their age. And thirdly, drug dosing. This is a very complex issue. We really can't even discuss it much in the few minutes I have. But we can introduce you to the concepts that you need to use when you go into the literature and begin to understand why certain groups of drugs and individual drugs are addressed in the way they are with obesity compared to the normal pharmacology. First point, are obese patients at greater risk for vomiting and regurgitation after fasting? And the answer is no. Their pH and gastric volume is almost indistinguishable from the normal size child who's fasted. But there are some differences that apply to the obese child, and that is we have to have appropriate size monitors, particularly blood pressure cuffs, or we'll have erroneous readings. And in some adults, we have to put the blood pressure cuff on the forearm because we can't fit a large cuff on the upper arm. Mask induction can be difficult. They have a greater incidence of obstructed airway. They have a greater incidence of bronchospasm and distension of the stomach with gas, which may lead to regurgitation and aspiration. And these also similar problems occur at the end of the anesthetic. Difficult IV access, as I mentioned, whether you need ultrasound or transillumination, it may be a problem. And IV access successes are only 2/3 as likely in obese patients. And lastly, is laryngoscopy a serious problem? The biggest issue that we have to deal with. In fact, airway complications head the list of problems with desaturation, multiple laryngoscopy, grade 2 mask ventilation, rapid sequence induction often being used, and laryngospasm. Much greater in the obese patient. Almost all of these are statistically significant compared to the healthy patient. So they do present in and of themselves greater incidence of asthma and greater serious problems with the airway, both intraoperatively and postoperatively. So what do we do to optimize the airway? Well, in the normal patient, we put them in a sniffing position with a little headrest, and this is not the neonate, this is the older child or adult. Now, what that does is flexes the lower cervical spine. But in the obese patients, if you raise their occiput 7 centimeters, that doesn't give you any movement of the cervical spine. In fact, in the obese patient, we have to ramp the patient, ramp up their back, and sit them up, and raise their head about 14 centimeters. And the reason is, if you can imagine, you wouldn't believe that this patient is lying flat on the table because she doesn't look it. She looks like she's lying head down. But actually, she's got a large pad of fat behind her cervical spine and upper shoulders. And what that does is it raises her larynx. This woman is the same woman, but with a double size occiput elevation and has 35 degrees ramped up. Now, I'll show you the trick in these two pictures that we're going to see on MRI in a moment. That is, the position of the tragus compared to the sternal notch, which is in between here somewhere. The tragus is below the sternal notch. In this picture, the tragus is above the sternal notch. If you insert the laryngoscope, as I have watched some nurse anesthetists I worked with do, and I said, you're in this position, this patient, you will see nothing. And they did not see anything. And they had to call for the glide scope while I repositioned the patient. And when you put the patient in this position, the larynx is right in front of your nose. So, first of all, ramping the patient reduces the time, increases the time till desaturation because you get better oxygenation because the diaphragm is lower. 200 seconds versus 155. That makes sense. That buys you more time to do the laryngoscopy. But in reality, if you do a good occiput lift, that shouldn't be necessary. And here's why. We got surface anatomy and MRI. Here is the tragus. And the tragus is basically right in front of the clivus at the base of the skull, which sits where the nasopharynx is, which is C. That's the supine position. And then when we put the proper occiput and ramp on this patient, what happens to the tragus? It is opposite the clivus, but the nasopharynx, C, is not where the clivus is. It's elevated. So that when you put in the laryngoscope, you're looking down onto the vocal cords. In the upper panel, if you inserted the laryngoscope, you'd have to look upwards somehow to see the vocal cords. That's why you don't see them. So ramping the back and doubling the occiput head lift are crucial. The tragus must be above the level of the sternal notch on the profile view when you're watching how you've aligned your patient in order for you to visualize the larynx easily. So we have to now talk about pharmacology, and this is really complex and a big issue. We have a patient 250 pounds, 120 pounds. What's the difference? Well, there's a lot of fat, certainly fat on the outside of the body, shown here in yellow, and there's also fat all around the intestinal cavity, none in the normal-sized patient. Extra weight, patients walking around with that. They also have fatty infiltration of the liver. Liver may be affected, and you get steatorrhea. The cardiac silhouette, look how much larger it is in this patient. Why? Because they've got to carry that extra weight. Now you understand that not only is the obese patient obese because there's extra fat, but they have hypertrophied vital organs, specifically muscles like the heart and the skeletal muscles, to carry the extra weight. Well, that means their lean body mass is increased. Most people don't appreciate that the obese patient is not just added obesity. So the drugs that are distributed in fat, they take a long time to go in and a long time to come out. That's really not the problem. In the obese patient, their vessel-rich group, the heart and then the muscles, they're hypertrophied. They take up more drug. That's why the doses must be adjusted to based on an adjusted body weight. So now we look at the obese adult, and we see them as a total body weight, but it's broken down into two components. The fat, we saw that in the last picture, and the fat-free mass. And this fat-free mass is their lean body weight or adjusted body weight. This is some measure of the total body weight minus the fat. And it's divided into the normal body conditions. So what we want to know is, where's our drug going? Is it going into the total body weight, or is it going into the lean body weight or the fat? And it depends on its lipophilicity. The one thing that's very interesting is that while total body weight goes up, so does fat. But the lean body mass, the amount of hypertrophy of the skeletal muscles and vessel-rich group, actually flattens off at above 50 BMI. So it doesn't continue to increase. So we have to be very cautious of that in the morbidly obese patient. What does that mean in the child? In a child, we have some drugs like, what happened there? Yeah. Some drugs like succinylcholine and propofol that are distributed in the total body weight. We have some that are delivered in the ideal body weight, and I told you the formula for that. Ideal body weight, such as morphine, both acutely and induction and chronically. Or there's some that are the lean body weight or adjusted body weight. And how do you calculate that in a child? You take their ideal body weight and you add a third of the difference between the total body weight and the ideal body weight. So this graph from Mortensen summarizes some of the pharmacology of the drugs we know and use in pediatric anesthesia and the best pharmacokinetics, but it's not perfect. It's not perfect because it's constantly changing because there are few studies in obese patients. And every time new studies come out, we see new information. But for all intents and purposes, plasma protein binding doesn't change, regional blood flow doesn't change, hepatic enzyme activity doesn't change much. This is all a matter of volume of distribution and excretion. So let's ask, what about the inhalational agents? Which one should you use? If you want to have the guaranteed fast recovery, you use desflurane, because it doesn't matter what the BMI is in the obese patient. You can give desflurane for as long as you want. They wash it out very quickly. But if you look at the sevoflurane rate of recovery and their response to command to swallow, it's markedly reduced with a BMI greater than 30. So desflurane is the agent to use. Propofol, no matter how well the pharmacokinetics are shown here on the slide and were tested and studied with Abyss, even the best pharmacokinetic data in the obese patient produced an overdose. Their BMI was very, very low. Lower than we would have predicted by the best data. So we need more research on pharmacology and pharmacokinetics of these drugs in obese patients. So I conclude by suggesting to you that when we wake up the patient PACU, we extubate them awake, keep them head up to improve their oxygenation, avoid excess opioids, and admit them to hospital if necessary. Thank you very much for your time.